Dr. Shashi, and thank you, my great friend, Dr. Rajesh, for having me in this prestigious meeting, giving me great opportunity to strengthen the bond of the Indo-Egyptian collaboration in scientific issues. So my talk today about one of the most crucial and controversial subject in ophthalmology, and we are the refractive surgeons always struggling with the pediatric ophthalmologists about this. To leave our patients with unilateral high error and anisometropia with their glasses for a life or turn to the refractive surgery. So starting with this consideration, the laser vision correction, when mentioned, it means always unilateral procedure, never bilateral. And quick introduction about the anisometropia. It's a condition where there is a difference of refraction between both eyes with more than or equal to 2 diopters, either myopic, hyperopic, or antimetropic, in which the patient or the child get one eye myopic and the other eye is hypermetropic. The treatment options should be in this order: the spectacles, the first line, then the contact lenses, if available and tolerable, and then shifting to refractive surgeries, including the laser corneal refractive surgeries and the phakic IOLs. The aim of treatment is for the prevention and treatment of the anisometropia and subsequently the anisometropic amblyopia. The amblyopia simply means that the eye and the brain don't work in harmony. There's misconnection between the eye and the brain, and the eye is typically normal, while the amblyopia is the difference between both eyes' visual acuity of 2 lines or more. Actually, the amblyopia is the most common preventable cause of the visual loss in children. So we are in need for awareness programs for parents and as well as the ophthalmologists. Stages of treatment which I respect in all my works. The first stage should be the glasses, only the glasses correction, either the full correction or the partial correction till reaching the full correction, together with the patching of the sound eye to enhance and stimulate the lazy one. And this stage, in my study, I followed for complete 6 months of the full correction by the spectacle and the patching together, starting the patching for one hour per day for 1 month, then 1.5 hours, 2 hours, 2.5, up to 4 hours per day during the period of the follow-up. Then the second stage will be the refractive surgery and patching after this surgery. The contact lens, when I got a patient with good tolerance and good behavior with the contact lens, I will left him to complete. But actually in these ages, it's so dangerous and so risky for these children to wear the contact lens because of they may miss it or got infected cornea. It's prospective study. 82 children included in this study first, and then just 11 be out from this study because of they were not compliant with the protocol of this study, so I excluded them. So there remain 71 divided into 12 patients completed with glasses because they showed a good correction for their vision and with response and a good response with the patching too. While the remaining 59 patients went for refractive surgery. The 59 patients with mean age of 7.3 years were undergone the corneal refractive procedures including LASIK, femto-LASIK, and PRK for treatment of that condition. The preparation, the full examination, the preparation with the psychoplastic refraction, unaided and best corrected, using the Snellen chart, the pentacam, and this image shows how this child with 4.5 years could be compliant on capturing the pentacam in our center. And then the mesopic pupillometry to consider the pupil size and the optical zone correction. The procedures were as follows: LASIK in 39 eyes, femto-LASIK in 6 eyes, and PRK in 3 eyes. Anesthesia was topical anesthesia mostly, but I used general anesthesia in the children who were under 4 years because they wouldn't be cooperative. And also the post-operative care like that in the normal LASIK patients. And these are small videos from my procedures. How to hand the flap and how to use the suction ring on the low vacuum technique to support the globe in case of the general anesthesia and in the topical anesthesia with uncooperative child. After creation of the flap, I will leave the suction ring in place under the low vacuum technique to support the eye and trying to centralize it. Then removing the flap and put it on a side, and then after laser ablation, I will reposit it again. And this is other view. This patient, this child was 8 years, so she was cooperative, and there was no need for the suction ring. And PRK with alcohol-assisted epithelial removal to get a smoother surface and easier epithelial removal with use of the mitomycin in the all cases for 20 seconds. So we are waiting for the results of that work, which the results means correction of vision, response to patching, and correction of squint. Results were depending on the type of the error or refraction. The myopics showed a marvelous improvement, either spherical or compound astigmatism and mixed astigmatism too. The high probes showed less improvement than myopics. The presence, type, and duration of squint also a very great and important factor in the results. The squint was in 29 patients with exotropia in 27 and esotropia in just 2. The type of fixation, either centric fixation in 25 and eccentric in just 4. So all these factors are very important in the results of that work. Also, it's surprising correction, really. Gain lines were much more than expected. The gain lines were 4.6 with this standard deviation lines, but with eccentric fixation, they showed longer, slower, and limited correction. The refraction was stable with increasing improvement of the visual acuity throughout the follow-up period. Patching not needed in 6 children. These showed marvelous improvement, more than 6/12 unaided. In others, it showed rapid, hopeful progress. No significant complications were reported in all groups. So I can conclude with these tables that only 26 of cases with squint needed adjuvant surgery. Patients completed with glasses showed at their most achievement best corrected, more than best corrected. It's more than 6, 12, and 60%. And so after 2 weeks of the laser vision correction, the unaided post-operative visual acuity was 4.7, increased lines, and gaining lines with eccentric fixation as above. Gaining lines with eccentric fixation was much less, was 1.3. So at the end of the follow-up period, which 6 months after patching, they gained 5.3 as above with eccentric fixation, and much less 2.4 with eccentric fixation. Okay, we'll have just a minute to show examples of surprising cases of this work. This cute girl, 5-year-old, with right high myopia and exotropia. The right eye refraction was -8, -8 sphere, -2 cylinder. The left eye was +1. With glasses and patching for 6 months, she had best-corrected visual active 160 just. 2 weeks after LASIK, unaided visual acuity was 660, really. 6 months after patching, the unaided visual acuity was 69. The exotropia is corrected from 40 present diopters to 20, as shown in these figures. This is pre-operative, and this is post-operative after 6 months. The second case, 4-year-old girl, right high myopia, and left eye is okay. Right was -6, and also the same with patching and the glasses. Best corrected was 360 after 6 months. 2 weeks after LASIK, unaided was 660. 6 months after with patching, the unaided becomes 612, 618. The exotropia almost corrected from 45 to 15. As shown, this is pre-operatively and post-operatively. The most and the last surprising case.
Sir, could you please conclude this? Thank you.
Okay, this is the last slide.
Yeah,
last slide. The most surprising case, 16-year-old girl, left amblyopic nose squint. She was not glasses wearer, so the unaided visual acuity 2 weeks after left LASIK is 636. Despite the best corrected visual acuity was 460, and her age is out of the common ages of correction. So we were so happy and surprised with this unexpected results. Age, refraction, dense amblyopia. So the conclusion, anisometropy is a common cause of amblyopia. I do recommend laser vision correction for treatment of anisometropia and amblyopia if primary optical methods have failed after adequate plan in a certain time, not more than 1 year. I have found it a very satisfactory and safe procedure. So to my colleague, please don't hesitate to take your valuable and critical decision at the suitable time and following the ethics and evidence-based medicine. And thank you very much.
Thank you, sir, for a very less looked at area of treating children, especially in these cases. I have a question, and if others, before that, we have Dr. Rajesh Sinha, Professor Rajesh Sinha, who has a very large experience in this country in refractive and corneal surgery. And while he sets up, so sir, how do you ensure fixation in small children during the procedure?
The fixation simply by you mean the centric and eccentric fixation?
No, how do you ask the patient, child, to look into the
fixation during surgery?
During the surgery.
During surgery, yeah. Okay. Either the child chose cooperation from the start on table of the machine, and by the kind dealing and by the patience with him will follow the light. I will show fixation by the pupil mark. As usual in the older patients, in the adult LASIK, you will show fixation when the patient is looking at the green light in AIOC2020 machine. Will fix the green dot all the time. So if I could find that, I will complete. Otherwise, I will use the suction ring under the low vacuum technique to centralize, to help centralization and fixation and capturing the images by the machine itself.
Thank you. RC?
Can you
Thank
tell
you very
something
much.
about this low vacuum, because I don't think SBK and other machine has got. Dr. Rohit, do you have something like low vacuums of this SBK, any of this machine? Because how do you ensure
How
the
do you
low
get
vacuum?
low vacuum? Which keratome are you using?
I'm using the Moria machine.
Which one? Because the SBK and we do not have any
We
facility
don't have a
to-
setting on SBK for low vacuum.
vacuum.
So how do you get low
Not
vacuum?
the SPK, the other Moria machine, which is commonly used in the microkeratome, the microkeratome, not the SPK.
Can you enlighten us on the previous version of the Moria machines?
Yeah.
So do you have that concept of low vacuum on any of these?
Okay, I think we'll let it leave at that. Thank you, sir, for yes.
Just a word. The normal vacuum used, what's the normal vacuum used in the LASIK cases with the Moria?
Around
60?
No, the machine which reads, I think it is around 700. Right? Around
600. Yeah, I'm going down to 4.
Can you do that?
Yeah.
Thank you.
Okay.
Thank you, sir. Yeah, Dr. Sinha, please.